So this chapter just talks a little bit about some important things to note about when dealing with um, pregnant women or pediatric patients when it comes to pharmacology. Um, so in pregnancy, we're obviously more concerned about use of any drugs because the fact that they may end up entering the fetal circulation. And there's a number of factors that affect the probability that a drug is going to enter the fetus's blood supply in any significant concentration. And this involves how easy is it for the drug to cross the placenta. And these are the 5 factors that have significance on that. Lipid solubility and ionization, molecular weight, protein binding, certain metabolic pathways, and duration of therapy. So, as you imagine, the more lipid soluble, the less ionized a drug is, the more easy it is to transfer across the placenta and into the fetus's circulation. Smaller drugs of smaller molecular weight are also just easier to transfer them by diffusion. Drugs that are less protein bound tend to be more likely to cross the placenta. When the fetus does not have sufficiently developed metabolic pathways to metabolize drugs, then they are more likely to cause issues. And then the longer the duration of exposure, obviously, the more likely there is to be some concern of high concentrations getting into the fetal blood. From a developmental point of view, as you have heard in other contexts, um, the first 8 to 12 weeks of fetal development, the most likely result of drugs being exposed to the fetus is going to be prenatal death. In the developmental period, anywhere from about um, uh, uh, 10 weeks to maybe the end of the second trimester. More likely, there is concern for significant morphologic problems to occur as a result of drug exposure. And as you get into the later part of the pregnancy, the later third trimester, there's still the opportunity for drugs to cause significant birth defects, but to the extent that many of the organs have already gone through significant development, the effects are more likely to be less benign, more benign. So the term teratogenicity is used when a substance produces a characteristic set of malformation at a specific stage of fetal development, and there is some evidence of a dose response, meaning that the more the drug the fetus is exposed to, the more severe the side effects. We mostly think of teratogenicity as being associated with morphological or developmental problems in the fetus, but it can also cause more global problems such as intrauterine growth retardation or miscarriage or stillbirth or generalized neurocognitive delays. So, in terms of their teratogenicity, drugs are classified in a standard manner, and this slide shows that. So, drugs can be either A, B, C, D, or X with respect to their risk of teratogenicity. So, category A drugs are those in which studies have been conducted in pregnant women and they have failed to demonstrate any evidence of uh, uh, danger to the fetus in the first trimester. Category B are where either animal studies have not demonstrated a risk, but human studies are not available, or animal studies have shown an adverse effect, but studies in women have not confirmed those results. C is where studies in animals have revealed adverse effects, but there have been no studies done on women. And then there's category D, where there is evidence of human risk, but the benefits may outweigh the risk. Finally, then category X are when studies in animals or humans have demonstrated problems and there's no context in which the drug would be recommended because the risks clearly outweigh any possible benefit. So there's not a lot of category A drugs because there's not a lot of studies in humans, pregnant women, on a lot of the drugs that we have out there. So a lot of drugs are going to fall in the B or C category, where B drugs, they have not demonstrated any risk in animals, therefore we have no reason to believe that they will harm humans. Category D drugs are some of the anti-seizure drugs that we talked about earlier in the course. The main issue there is that, yes, they may cause problems. However, having a patient with epilepsy have intractable seizures during pregnancy is also going to be associated with problems. So there are certain drugs, there are certain times when those drugs are, recommended to be continued, and, caution taken in terms of ultrasound of the fetus, etc., to identify potential side effects. In terms of, what about after pregnancy, the drugs that women may use while they're breastfeeding? In general, there's not considered to be a whole lot of harm from drugs that women use while breastfeeding, because the concentrations that occur in the breast milk are just not high enough to cause any significant problem. The two notable exceptions I have here are tetracyclines and lithium. As we talked about, the tetracyclines can cause problems with cartilage and bone development and discoloration of the teeth, and lithium can have toxic effect on the kidneys. Little bit about the use of drugs in kids. In general, kids have a wider extracellular or a larger extracellular fluid volume, meaning that the drug is diluted in a larger volume. They have less protein binding. They have relatively immature livers that can have a harder time metabolizing drugs than adults, and a lower glomerular filtration rate, meaning that they tend to excrete drugs less quickly than adults. The main name of the game with drug dosing in kids is weight-based. Pretty much everything in children is weight-based, and if you get a chance to do pediatric rotations, the first few weeks are a little bit unnerving because kind of everything you have become familiar with in terms of adult dosing goes out the window, because you're going to get kids of all sizes and shapes, from 18-month-old kids to 10-year-olds that are probably bigger than me, and you're going to have a huge range of dosing, and you really have to simply do everything on a weight basis.